Hello everyone, I'm Dr. Rohan Khandelwal, your Marrow surgery faculty, and in this video I'll be talking about the fourth part of the FMGE potential questions, in which I'm going to talk about urology. Rest of the parts, that is general surgery, trauma, breast and endocrine, thyroid and vascular, and GIT and hepatobiliary have been covered previously, and all three videos are there on my YouTube account, and you can go and see those videos before your exam at 2x speed. If you watch these videos in total, all the combined duration is around 2.5 hours, and that would be enough for you to do well in your surgery portion. So moving on to the urology questions. A 65-year-old male presents with multiple episodes of painless hematuria. He has a blottable mass in the left flank. No WBCs are seen in the urine. Most likely diagnosis. So an elderly male coming with painless hematuria and a blottable mass in the left flank means a renal mass. This is renal cell carcinoma. Hematuria is the most common clinical feature of RCC. Pain and mass are the other clinical features. This typical triad is seen in 15% patients. This typical triad is only seen in 15% patients. The most common symptom is hematuria. Paraneoplastic syndromes are also common in RCC, and the most common is raised erythrocyte sedimentation rate. These are the other paraneoplastic syndromes. You really don't need to remember them for the FMG exam. Whether you want to call this a surgery question or a pathology question, the details regarding the types of RCCs are also usually asked. Which of the following statements are true regarding clear cell carcinomas? They contain glycogen and lipid. This is a true statement. Mostly sporadic. This is also true. They occur due to deletion of chromosome 3q. This is false. They occur due to deletion of 3p and not 3q, and they arise from PCT, proximal convoluted tubule, and not distal convoluted tubule. So 1 and 2 are the correct statements here which you need to know about. The most common type of RCC is clear cell. There is deletion of 3p and 6p. It can be associated with VHL, that is von Hippel-Lindau syndrome, but most of the tumors are sporadic in nature. They arise from the proximal convoluted tubule. Papillary renal cell cancers, hereditary papillary RCC syndrome can be there, but again mostly they are sporadic. You can get samoma bodies, this has been asked, and again mostly they arise from the proximal convoluted tubule. They can be associated with long-term dialysis therapy. Chromophobe type of RCC has the best prognosis, and this is the question which has been asked in the FMG exam. They can be associated with Birt-Hogg-Dube syndrome, and you can get plant-like cells and raisin-like nucleus. This is the slide which you can see. The slide has not been asked in the FMG exam. A 47-year-old man presents with a renal mass involving the lower pole measuring 7 into 4 into 2 centimeters. What is the preferred treatment option? So this is T1 disease. Now you need to know that renal cell cancers mostly occur in the poles. Superior pole is the most common, followed by the inferior pole. And T1 is up till 7 centimeters. So if you have a single lesion in the poles up till 7 centimeters, you can carry out a partial nephrectomy. You don't need to carry out a radical nephrectomy. Also, you should know that renal cell cancers are chemo and radio resistant tumors. So surgery is the mainstay of treatment in renal cell cancers. The indications for partial nephrectomy: you have T1 tumors restricted to the poles, if you have bilateral renal cell cancers, or renal cell carcinoma in a solitary functioning kidney. The relative indications are RCC in a kidney where the other kidney is affected with hydronephrosis or stones. But these 4 indications you should definitely remember for partial nephrectomy. Invariably, there is one question from renal stones. In the last 3 FMG exams, renal stone questions have been very common, so you should know about renal stones. The most common type of renal stones are calcium oxalate stones. So calcium oxalate stones are the most common. They are radiopaque and they are found in acidic urine. Calcium oxalate monohydrate stones are very hard stones. We also call them dumbbell-shaped crystals. Triple phosphate or struvite or staghorn calculi is calcium, magnesium, ammonium phosphate. They are formed in alkaline urine, which is usually infected due to Proteus, and this has also been asked in the exam. These are also radiopaque and they can grow up into large stones before they become symptomatic. Cystine stones are very hard stones, they are the hardest stones and they have a crystalline lattice. They are formed in acidic urine. Uric acid stones are radiolucent, they are the most common radiolucent stones and they can be seen in gout and tumor-lysis syndrome. So calcium oxalate crystals can be envelope shaped or dumbbell shaped. Uric acid are like glass shards, all shapes and sizes. Struvite stones are like coffin lid crystals, and cystine stones you have crystalline lattice. This is again a very frequently asked question, almost been asked 3 times in the FMG exam. A 5-year-old girl comes with continuous dribbling of urine with normal voiding pattern. What is the most likely cause? So there is continuous dribbling also and she can hold also. So this occurs when there is duplication of the ureter and one of the ureters is opening in the ectopic position. So this is duplication of the ureteric system. This is known as Weygert-Meyer's rule, where one of the ureters, which is usually draining the upper pole, it opens distally and ectopically. So in females, it will open in the vagina, which is why the girl is having continuous dribbling, because there is no control. If urine goes in the vagina, there is no control there. You can't stop it. And because one ureter is going in the bladder, there is control also. So normal voiding pattern plus continuous dribbling. This is the telltale sign of duplication of the ureteric system. Whittaker test, this is just a factual question which has been asked once. It is done in hydronephrosis. Imaging of the renal tract is done and it is shown below what is the likely diagnosis. So here you can see a kidney where there is calcification. So such a calcified kidney is known as a putty kidney, and this is seen in tuberculosis of the kidney. So in tuberculosis of the kidney, you can get putty kidney and cement kidney. Putty kidney is when there's pus and cement kidney is when it becomes calcified. These are the changes which can occur in tuberculosis. You should also know that the earliest change in renal tuberculosis is a papillary ulcer. One more question which was asked 3 years back in the FMG exam, that tuberculosis of the genitourinary system can even give rise to a golf hole ureteric orifice, means the ureteric orifice remains open. And if the ureteric orifice remains open, it leads to reflux. Okay. This is a perinephric abscess which you can see. This is renal tuberculosis. This image has been asked many times in the exam. Image of a newborn child is shown. What is the likely diagnosis? This is ectopia vesicae. In the previous video, in part 3, I've already told you about omphalocele and gastroschisis. They are also frequently asked. So you can look at the third part on my YouTube channel where you can know more about omphalocele and gastroschisis towards the end of the video. Here you can see that the bladder is exposed. The anterior abdominal wall is deficient below the umbilicus and the bladder is exposed. This is ectopia vesicae or bladder extrophy. This was asked in a recent exam. A 35-year-old male comes to the OPD with right flank pain. CT image is shown, which is incorrect statement. So you can see these multiple cysts in the kidney, right? So this is because of echinococcus infection, right? Echinococcus infection has caused this, or it has given rise to a hydrated cyst in the kidney. So albendazole should be given. This is true. It is caused by tapeworm. Leakage of cyst can cause anaphylaxis. FNAC should never be done prior to surgery, because if FNAC is done, it can give rise to spillage. So this is caused by Echinococcus granulosus, not caused by dog tapeworm, and we don't do an FNAC prior to surgery. A child is brought to the clinic for evaluation of recurrent UTI. Intravenous urogram is shown. So these images are very important. This is your inverted lily sign, right? Inverted lily sign, and this is also seen in duplication of the pelvic system. In horseshoe kidney, here you can see duplication of the pelvic system. Here you can see and horseshoe kidney, what will you see? Horseshoe kidney, we will see a flower vase sign. We see a flower vase sign in horseshoe kidney, and horseshoe kidney, you should know that it is usually fused at the level of L3 and L4. It is the inferior mesenteric vessels which prevent the ascent of the kidney, and we should never resect the fused portion. So you can see a horseshoe kidney here. Both the lower poles are fused. All patients should undergo resection of the fused portion. That is false. Majority of the patients are asymptomatic and incidentally detected. Adrenal glands are not on the ectopic location, and inferior mesenteric arteries restrict the ascent of the kidney. This is also true. Okay. So 20-year-old male presents with sudden onset pain in the right inguinoscrotal region. On examination, the right side is higher up in position and tender on palpation. What is your diagnosis? So you have a young male with sudden onset right inguinoscrotal pain. The testis is higher up in position and tender to touch. These are all signs of testicular torsion. Why isn't it epididymoarchitis? Because if it was epididymoarchitis, lifting of the testis would have reduced the pain, right? Whereas in torsion, if you lift up the testis, it increases the pain. So to differentiate whether it is epididymoarchitis or torsion, there are clinically 3 signs which can be done. Pren sign, if you lift the testis, pain reduces in epididymoarchitis, it increases in torsion. Angel sign is a transversely placed testis in torsion, and Deming sign is that the testis which has undergone torsion lies at a higher level. A patient working in the dye industry presents with bladder cancer. Again, a very common question. This is transitional cell carcinoma. In bladder, transitional cell carcinomas are the most common. And you can remember the risk factors as 3 C's: cigarette smoking, chemical dyes, and cyclophosphamide, which is an anti-cancer drug. Squamous cell carcinoma, you can remember the risk factors as 2 S's: schistosomiasis and smoking, and this is usually seen in African countries. Again, bladder cancer patient is going to come with massive hematuria. That will be the most common presenting feature. A 10-month baby is brought to the hospital by his mother. His right testis is in the inguinal region, whereas the left testis is in the perineum. What is the diagnosis? Now, they have twisted this question over the last 2 years and they've asked it repeatedly. So, undescended testis, ectopic testis is extremely important for the FMGE exam. So, because the right testis is in the inguinal region, it is an undescended testis. But left testis is in the perineal region. It is deviated from the normal path. So the left testis is going to be an ectopic testis. So what we are dealing with here is right undescended and left ectopic testis. So undescended testis, when it is arrested along the normal path, and the most common site is the inguinal canal. But if it deviates from the path, we call it an ectopic testis. And the most common site for ectopic testis is the superficial inguinal pouch. So please don't make this mistake. You have to read carefully. If they ask ectopic, then it is superficial inguinal pouch. Whereas if they ask undescended, it is the inguinal canal. A 5-month baby is brought to the OPD with bilateral undescended testis. Now, bilateral undescended testis is known as cryptorchidism. What should be done? So if there is cryptorchidism, there is a role of giving GnRH injection. A single GnRH injection should be given in these patients. And if after giving the GnRH injection, if till 6 months of age, if the testes don't come out, then we will carry out orchidopexy. Okay, so we wait till 6 months for spontaneous descent, but in cases of bilateral undescended testes, we will give a GnRH injection. 40-year-old male comes with a testicular swelling and another swelling over the umbilicus and in the right supraclavicular region. What is the most likely diagnosis? So this is a testicular tumor because there is a testicular swelling above the umbilicus are retroperitoneal lymph nodes, and you can have supraclavicular lymph nodes as well. These are all signs of a testicular tumor. Testicular tumors, you should always remember, we never do FNAC or biopsy in a patient with suspected testicular tumor. Again, Fournier's gangrene, last 3 years, 3 exams of FMG have asked this. You should know about this. Elderly male with sudden onset pain in the scrotum and discharge based on the image shown below. This is Fournier's gangrene, which is a necrotizing fasciitis involving the perineal region. It is usually a mixed microbial infection, that is aerobic plus anaerobic. We also call it synergistic gangrene. It is usually seen in immunocompromised patients, and the treatment is aggressive debridement and broad spectrum antibiotics. You can see here the testes are usually spared because the testes have dual blood supply. Torsion, I have already told you, the risk factors are bell clapper testis, inversion, undescended testis, and cyst of Morgagni. And I have told you the clinical signs of how to differentiate torsion from epididymoorchitis. A male patient comes with painless enlargement of the testis. LDH values are raised. What is the next step in management? I told you painless enlargement of the testis, we should always suspect a tumor. And there are 3 tumor markers in testicular tumors: LDH, beta HCG, and alpha fetoprotein. These are the 3 tumor markers which we measure. So here the LDH values are also increased. Like I said, we never do FNAC or biopsy because in suspected testicular tumors, if you do an FNAC or biopsy, that can upstage the tumor. It can cause spillage of the tumor. So in suspected testicular tumors, we carry out high inguinal orchidectomy. Please don't make a mistake in this. This has been asked many times. It's a trick question. They want you to mark FNAC, which is why FNAC will always be as option A. What you have to do here is high inguinal orchidectomy. So this is the staging of testicular tumors. You don't need to remember the staging for your exam. You should just remember the 3 tumor markers which are there in testicular tumors. A young male comes with dull dragging pain in the scrotum. On examination, bag of worms consistency is palpated. So bag of worms consistency is characteristic of varicocele, which is nothing but dilated tortuous pampiniform plexus of veins. So dilated tortuous pampiniform plexus of veins is varicocele, and varicocele is a common cause of male infertility. It is a common cause of male infertility which you should know about. Hydrocele, you know, you will get fluctuation and you can get transillumination. It is accumulation of fluid in the tunica vaginalis, and fluctuation and transillumination can be seen in hydrocele. 50-year-old male felt heaviness in the scrotum. You're suspecting a cancer. Transillumination test is negative. No pain. What is the diagnosis? So it is a tumor, and if it is a tumor, we have to, like I said, high inguinal orchidectomy has to be done. So this question I've already covered. Old man with metastasis in the vertebrae and bones. Old man with the mets in vertebrae and bones, it is most likely to be prostate cancer. Had this been a female with mets in the vertebrae and bones, we would have marked breast cancer. Here it is prostate cancer. You should know that prostate cancer mets most commonly to the lumbar vertebrae. They are osteoblastic, more common than osteolytic. So blastic means bone forming more than bone destroying. And this question has been asked that how do these metastases or how do these cells reach the vertebral column? So they reach the vertebral column because of the Batson's plexus of veins. You should be aware of this. An elderly male is detected with carcinoma prostate. On evaluation, metastasis is found. Which of the following drugs is used in this patient? So like breast cancer, where if ER/PR positivity is there, we use hormonal therapy to block the hormones. Similarly, prostate cancer is also driven by testosterone. So in males who have metastatic prostate cancer, we can use androgen depletion therapy, ADT. We have to reduce the level of androgen, and we can do that by using leuprolide. Right, so metastatic cancer, orchidectomy, or we can use LHRH agonists like goserelin or buserelin or anti-androgens. Hormone resistant patients, we can use chemotherapy, radiotherapy. Siplucil T is a T cell vaccine, or we can use radiopharmaceutical therapy, which acts via alpha rays. This was asked last year, which grading system is used for prostate cancer? We use the Gleason's score for prostate cancer. Which isotope is used for treating or giving radiotherapy? It is iodine 125. Iodine 125 seeds are used in giving radiotherapy in prostate cancer. Iodine 131 acts via beta rays, and this has a half-life of 7 to 8 days. This is used for thyroid cancer treatment. This I've already told you in the second video, which is there on my YouTube channel. In the last 3 years, 2 questions have been asked regarding these RGU and MCU. So this is a simple question: urethral trauma. Mother gets a child to the urology OPD complaining of difficulty in passing urine since a few months. Urologist orders a test which shows the image below. What is the investigation? Okay, so you can see here you can see that dye has been injected from outside and it is going in. You can see dye is injected from here, it is going in. So this is an RGU, retrograde urethrogram. What is RGU? Retrograde urethrogram. When we push in dye from outside and it goes in. If dye was already in the bladder and then it comes out, then it is called an MCU, micturating cystourethrogram. But for suspected urethral trauma, and to visualize the anterior part of urethra, we do an RGU. Urethra, there are 4 parts. You have penile urethra, bulbar urethra. Penile and bulbar commonly are known as the anterior urethra, and the prostatic and membranous are known as the posterior urethra. Okay. A patient presents with hernia medial to the inferior epigastric artery. What is the most likely diagnosis and the management? This was asked last year. So medial to inferior epigastric artery, it is direct hernia, and we will do a Lichtenstein's tension-free mesh hernioplasty. The boundaries of the Hasselbalch triangle have been asked many times. So Hasselbalch triangle is bounded by the outer border of rectus, inferiorly by the inguinal ligament, superiorly by the inferior epigastric vein. Any hernia which lies lateral to it is indirect, and any hernia which lies medial to the inferior epigastric vessels or inside the Hasselbalch triangle is a direct hernia. Irrespective of whether it is direct or indirect, we do a Lichtenstein's tension-free mesh hernioplasty. Which of the following does not form boundaries of the myopectineal orifice of Frouchard? So arching fibers of internal oblique form the superior boundary, iliopsoas forms the lateral boundary, Cooper's forms the inferior boundary. Inferior epigastric vessels are not a boundary. The medial boundary is formed by the outer border of rectus. By the outer border of rectus. Right, triangle of doom and triangle of pain have also been asked many times. Which of the following does not form boundaries of these triangles? So vas deferens does. Peritoneal reflection, gonadal vessels. Cooper's ligament does not form a boundary of these triangles. Triangle of doom is bounded by the vas deferens medially, testicular vessels laterally, and the peritoneal reflection inferiorly. This lies medially, and external iliac vessels and the genital branch of genitofemoral nerve lie in this triangle. Laterally lies the triangle of pain. You have the triangle of pain, and here three nerves: lateral cutaneous nerve of thigh, femoral nerve, and femoral branch of genitofemoral nerve lie here. The most commonly injured nerve or entrapped nerve during laparoscopic surgery is lateral cutaneous nerve of thigh, and this can give rise to a symptom complex known as meralgia paresthetica. The significance of these two triangles is that in these two triangles, we should not put a stapler or suture because we can injure these structures. So, patient underwent inguinal hernia surgery and there's sensory loss in the root of the penis and scrotum. Which nerve has been likely injured? It is the ilioinguinal nerve. During open surgery, ilioinguinal nerve is the most commonly damaged nerve. This I had already covered in the previous video. This is congenital diaphragmatic hernia, which is also very important. And in the previous video, I've told you the most common type of congenital diaphragmatic hernia is Bochdelic hernia, which is left posterolateral. Morgagni, on the other hand, is right enteromedial, right? Patient usually dies because of pulmonary hypoplasia. That is the leading cause of death in these children. So these are the questions regarding urology and hernia. I've covered all four parts, entire surgery in a nutshell. These high yield topics are there. Please watch these four videos before your FMG exam. Also, my advice: in the last 10 days or so before your exam, every day 2 to 3 hours, just watch the recall videos of previous years. So at least last 2 to 3 year recall videos of all subjects you should watch. If you can do those thoroughly also, you will be in a very good position to clear your exam. All the very best. See you on the other side. Thank you.